Welcome everybody. My name is Sane and I am a service navigator for Central Eastern Sydney Primary Health Network. My colleague Bertha is also with me, and she'll be supporting both myself and Bertha will be supporting Tony in this presentation. So first we'll just do acknowledgement of country. So Central Eastern Sydney Primary Health Network acknowledges the Aboriginal and Torres Strait Islander peoples of this nation. We acknowledge the traditional custodians and sovereign people of the land across which we work, and we recognise their continuing connection to land, water and community, and pay respect to elders past, present and emerging. The initial assessment and referral decision support tool is a tool that's been rolled out by CESPN. It provides primary healthcare with nationally consistent, evidence-based and objective approach to initial assessment and referral of patients seeking mental health support. It's a comprehensive training package and is available to all GPs in the CESPN region. GPs will be paid upon completion of the training, and the RACGP CDP points are available. So for more information, just visit that website. And also just a reminder about Head to Health, free mental health help. There's a new service in Canterbury. Just call the 1-800-595-212 or drop in. It's open between Monday to Friday, and yeah. On that, I would like now to introduce our speaker for the night, Tony. Tony has been a practicing clinical psychologist for 25 years. He owns and runs Sydney Clinical Psychology in Newtown and Penrith Clinical Psychology in Penrith, as well as Inner West Pain Centre and Western Sydney Pain Centre. He is a lecturer in clinical psychology at University of New South Wales and several other universities. Tony's been practicing, Tony's practice is now one of the largest provider of DBT services in Sydney. Each year they treat hundreds of people struggling with suicide ideation, self-harm and other complex and severe psychosocial problems. The floor is yours, Tony.
Thanks very much. Cheers. Thanks very much for the opportunity to come along tonight. So I'm going to try and do something tonight that's kind of a little unusual, really, because I suppose talking about self-harm to GPs, there may be a bit of an expectation that what we're going to talk about is a whole bunch of things around risk factors and identification of people at risk and risk stratification, but that's actually not what we're going to do tonight. So I hope you're not disappointed. What I'm going to try and do instead is do something that I'm not aware of anybody having done this, which is to try and take some of the principles of DBT and provide a way for you as primary care physicians to use some of these ideas managing people who are suffering from these kind of problems. And why am I doing that? Well, because it turns out that according to DBT, the principles that the DBT theory was built on are universally applicable. And not only that, but we recognise that things like self-harm and suicidal ideation and drug and alcohol and a whole bunch of other problems don't occur in isolation. They occur in the broader context of someone's environment and in the transactions that the person has in that environment. So general practice physicians can play a key role in actually helping to kind of reduce self-harming and suicidal behaviours, and then therefore feed into the overall treatment program. So I'm trying to do something a bit different tonight, and I have my fingers crossed that it'll work out. But what I'm really hoping to do is at the end of this, I'm hoping that we will that you will go away with some real, genuine, practical tools that you can use for working with people with these kind of problems. And this is kind of not unusual in the sense that we work a lot with, obviously we work with clients providing DBT therapy. We also work with other organisations. So we work with a number of NGOs way back, for example, helping them to provide DBT consistent services. And so this feels very much for me like an extension of that. And as mentioned before, if you've got any questions as we go, just pop them in the chat, and I'm happy to kind of answer them as we go. However, there will be plenty of time at the end for questions. So I'm going to talk for about 25 minutes or so, half an hour, giving you just a brief overview of DBT and what it actually is at a very kind of high level, conceptual level. And then I'm going to go into some ideas that come from DBT that I think can be used in primary care by you guys in order to help people with these kind of problems. Then I'm going to present a case study, and we're going to drop into some small groups for an exercise for about 25 minutes, and then we'll come back to the large group to discuss that. And we'll allow around about 25 minutes for questions at the end, which will be a broad forum for anyone to ask anything they want to ask. But it might be that as we go along, those things happen a bit more effectively as we go along anyway, so we'll just kind of see how we go. Okay. Sorry, it's going to move the window there. DBT really was developed for the treatment of personality disorders, and a lot of the time when we see problems with self-harm and suicidality, while it's not necessarily the case that it is connected to a personality disorder, often the other behaviours that we see that come with that are also the sort of behaviours you do see, in particularly in things like borderline personality disorder. And when we talk about personality disorder, we talk about something that's early onset in adulthood or teens, and is an enduring pattern of inner experiences and behaviour that deviates markedly from the social norm. And that concept of deviating from the markedly from the social norm is really important, because when you look at all the personality disorders, they all deviate in some way from the social norm. Antisocial personality disorder, narcissistic personality disorder, and indeed borderline personality disorder. And there's this enduring pattern of inflexible problematic behaviour. And what we see in people who are suffering from the kind of problems we're talking about tonight is that the inflexibility can be in their chaoticness. So it can be that the person is chaotic across multiple contexts. It doesn't matter how kind of safe and secure an environment is, or how challenging or difficult the environment is, the person will be chaotic. So their inflexibility can be in their chaoticness, or it can be in their rigidness. It's about the fact that they apply the same kind of approach and the same set of ideas to solving a whole bunch of life's problems. And that's really important when it comes to self-harm, because what you find that people who self-harm regularly and people who are regularly acutely suicidal is that what they're doing is they're applying the same coping strategy to a whole bunch of life situations. So they may apply that coping strategy to dealing with overwhelming trauma, but they may also apply that to dealing with an argument at work with their boss, or a difficulty at home with their parents, or even just a small issue that occurs with their flatmates. So it becomes a standard pattern the person applies to their lives. And so what I'm focusing on really is on the sort of the cluster A personality disorders, and in particular we're talking about self-harm and suicidality tonight, which are key features of those cluster A personality disorders, and to some degree the cluster B personality disorders, and to some degree in the cluster A's as well. So what we do know is that when it comes to personality disorders, the treatment of self-harm and so on, until DBT came along, there was a very long history of unsuccessful treatment of these problems. And that's because treatment providers tend to be focused on one of three things. Treatment was either focused on highly directive therapies like CBT, behaviour therapy and things like that, which are about being very change-focused and about helping the person to solve the problems that are in front of them. But what we found out through numerous research studies was that these therapies actually tend to make people worse. On the other hand, we have very supportive non-directive therapies, the sort of classic psychodynamic therapies, but also the kind of supportive counselling models and things like that. But what was found is that those treatments also make people worse. So there's a bit of a dilemma here. Change-focused treatments make people worse, support and acceptance-focused treatments make people worse. And then, of course, there's hospitalizations. And again, what was found with these particular groups of people when it comes to self-harm and suicidality is that this kind of process of chronic hospitalization actually makes people worse. And if anybody's interested and you read Marsha Lineham's memoir on the early parts of her life and her development of DBT, you'll know that she was actually hospitalized herself as a young adult and talks in that book at fairly great length about the experience of that and how that had such a negative impact on her overall functioning. So we're really in this kind of bind until DBT came along, where there was this kind of whole cohort of very complicated clients that really we didn't have any treatments for. And in fact, whatever we seemed to do made things worse. So Marsha Linehan initially tried to apply behaviour therapy to people with self-harm and suicidality. One of the issue of why borderline personality disorder is in there is relevant, I think, because, and I just want to make this point, is that when Marsha Linehan developed DBT, she actually developed it for the treatment of suicide and self-harm. But what happened was, back in the 1980s, is that the National Institute of Mental Health funded all these treatment programs in the States, would only fund treatment programs that were tied to specific clinical diagnosis. So she had to make a decision, and it was suggested to her that she either ties the treatment to severe depression or to borderline personality disorder, and she decided on borderline personality disorder. So it's really important, and the reason I make that point is because often DBT is referred to as the treatment for borderline personality disorder, and there are these inclusion criteria around borderline personality disorder, but actually it's a treatment for self-harm and suicidality. So when she was developing this treatment, she applied the classic behaviour therapy approach. She found they made things worse. She had this supportive approach. She tried that stuff. She found it made things worse. So what she decided to do was take a step back and try and develop a new theoretical approach to understanding self-harm and suicidality in the context of borderline personality disorder. And she developed this theory, which became known as the third way, which was about integrating these sets of ideas. Classic change-focused therapies about learning coping skills and about doing things different, with supportive-based kind of acceptance, validation-based approaches to treatment, and recognise that actually these things needed to be brought together in order to provide effective treatment. However, she wasn't just interested in the theory. She tested every aspect of this treatment program in the most minute detail in order to see what worked. And as I mentioned, a lot of this came out of her own personal experiences as a young person and being hospitalised and being unable to find effective treatment. So what does this actually mean? So now we have DBT, which really is the gold standard for treatment for borderline personality disorder. But in lots of ways, as I say, what we mean by that really is the treatment of suicidality and self-harm. It's also very effective for severe depression and the treatment of anxiety. You may remember that I said that when Marsha Linehan developed DBT, she actually considered whether to link the treatment to depression, but decided on borderline personality disorder as well. So we know that people who go through DBT, people who are severely depressed, get marked improvements in their depression and their anxiety. And it's also very effective for drug and alcohol problems. And again, we know that drug and alcohol problems are highly comorbid for this cohort of people. So there's very strong evidence for treatment of DBT for borderline personality disorder. Currently, Cochrane, I believe, there's 21 randomised controlled trials supporting the evidence for supporting this treatment. And at the moment, there's 83 DBT trials that are registered with the US National Register of Medicine, which is pretty significant, really. Also pretty good evidence for DBT with treatment for adolescents as well. And also evidence of DBT for other conditions that kind of feel like the sort of borderline presentation. So bipolar disorder, eating disorders, trauma, and of course, severe depression. So it's become a very, very useful treatment for a whole bunch of different problems and very strong evidence. So what is DBT? It's very easy to be mistaken into thinking that DBT is about teaching people a bunch of skills in order to improve the way that they cope with things. If any of you have looked at the DBT skills training manual, it's a very thick book with all of these different skills in there that we teach people in order to deal with their emotions. The challenge for DBT, though, is that when you look at those skills that we're actually trying to teach people, there's nothing in those skills that's particularly kind of original or difficult. They're all the kind of skills that most of you would have to some degree and would use in your life. And so DBT really is about understanding an effective way of teaching these skills to people who've been unable to learn them so far in their life. So where that starts off with is a very broad theory of personality development, of treatment, and indeed a kind of a world view, which is based around this sort of a very complex idea called dialectics, which I'm not going to be able to get into tonight, but it is a very interesting idea. I'm going to touch on it, but if you're interested in it, you can go and read some more about it. DBT is also a way of structuring therapy for complex problems. So if you know anything about DBT, you'll know that it involves individual therapy, it involves group therapy, it involves a thing called phone coaching, it involves a thing called consult group, and a family and friends group. And more, we're also trying to make it involve other services that are around people who have these kind of problems. So it's a behaviour change therapy with a usual emphasis on behaviour change, but also on the concept of validation, of addressing the therapeutic relationship, of addressing things that get in the way of people benefiting from therapy, and these things called dialectical processes. And as a treatment, it's also a way of structuring support for therapists. So DBT has these great assumptions, and this is, I think, is the first tool that you can use when working with people who have self-harm or suicidality, because these things become the foundational stance that you can take when you're sitting in the room with someone and when you're thinking about how to go about helping someone with these kind of problems. So the concept of dialectic is the idea that two things that appear contradictory can actually be true at the same time. And, you know, the classic kind of statement, the classic book on borderline personality disorder, that sort of thing, I hate you, don't leave me, you know, really reflects that concept of a dialectic, that someone with these kind of problems can feel a tremendous amount of hate towards someone and yet at the same time feel deeply connected and want to be around them. So it can be a very confusing world for clinicians working with these problems if you're trying to understand the logic and the rationality between someone's behavior. And if you're trying to understand which one of two versions of that person's behavior is the true or accurate reflection of what's happening for them in their world. What DBT says, and the concept of dialectic says, is that both those things can be true and are true at the same time. And once you can actually fully understand that and fully accept that kind of idea, it helps you to step back from this idea about trying to work out what's going on for this person. Does this person love this person, or do they hate them? Are they going to hurt themselves, or are they going to keep themselves safe? Do they have a strong relationship with you or not? Both, for people with these kind of problems, both those things can be true. And so what we try to do is step back from that and recognize that and accept that about people. So in these DBT assumptions, you'll see some dialectics in here, some things that look contradictory. And part of that is about accepting that both those things are true. So these are the assumptions of DBT. Firstly, we always make the assumption that the client is doing the best they can and that they want to improve their situation. However, they also need to try harder, do better, and be more motivated to change. So those things sound quite contradictory. And if you're looking for the logical resolution of those, it's kind of hard to put those together. But if you just wholeheartedly accept that both those things can be true at the same time, then a new synthesis of how you think about that person's problem can emerge. And then therefore, the way you approach that problem, a new synthesis can emerge as well. I think this one's really important. Life is unbearable as it currently lived. And it's really important that we recognize that for many of our clients, they really do have very difficult lives and very awful lives. You know, I've seen people who've told me that they had a client who told me that she had 2 friends on Facebook. And I was quite stuck, it's two friends in the world and they were both on Facebook. And I was quite kind of struck by that. And she got Facebook out and she showed me. And one of the friends was someone that this girl was in her 30s. One of the friends was someone that she'd been to school with when she was like 15. And the other one was a guy that she'd slept with 2 months ago. And they was the only people in the world that she kind of knew. And yet she was quite social, quite gregarious, kind of an interesting kind of character. But really her life was just awful because she just kept burning her relationships. So when we can accept that actually life is unbearable as it's currently lived for people, we can actually provide a very validating context for that person because they actually start to understand that you recognise just how incredibly difficult it is for them. New behaviours in relevant contexts must be learned. So that ultimately the way out of these kind of problems is through behaviour change, between doing things differently. And clients cannot fail in DBT. So any attempt by you to use DBT towards a client and that's unsuccessful isn't caused by the failure of the client, of the patient. So patients may not have caused their problems, but they have to solve them anyway. This is a really difficult one, and sometimes people find this quite difficult to get their head around, because often when you find people with these kind of problems, they often have very complex backgrounds and upbringings, but it's a kind of an important part of DBT, and we'll talk about this concept of radical acceptance a bit later. That the person has to accept that even though they may not have caused their problems, ultimately it's up to them to solve them. Most caring thing a therapist can do, or a doctor can do, is to help people change in ways that help them improve towards their goals. So this gets into this thing I was talking about before about these contradictions in the therapy. So we used to have this idea that either we were about behaviour change or we were about support. But it turns out that, and that was about being caring and supportive. Turns out from a DBT point of view that the view is that actually the most caring, supportive and compassionate thing you can do is to help people change. Clarity, precision and compassion are essential, so I'm going to skip that one. A therapeutic relationship is a real relationship between equals, and behavioural principles are universal and affect clients and therapists alike. So later on I'm going to talk a little bit about the concept of reinforcement and how that's relevant to self-harm. But it's important to recognise that whatever factors are going on for our patients and whatever factors are maintaining our patients' behaviour, we are part of that system and part of that problem. So while the clients cannot fail, DBT therapists can fail. And what that means is that you as doctors who are working with these people, you can fail. The idea of that obviously is the idea that you can't expect perfection from yourself. And it's important to recognise that no matter how hard you're trying to help people, sometimes you won't be able to help them when you will be unsuccessful. And indeed, the treatment can fail, even when the therapist does not. So again, what this means is that DBT is an imperfect process and an imperfect treatment, and it's not going to work for everyone. And people working with these people need support. And I think that's really important for you guys, that if you are working with people with self-harm and suicidality, and I suspect many of you are because that's why you're here, then you really need to make sure that you connect with some kind of supportive network of other colleagues in order to kind of work through these kind of things. So there's some really interesting principles. And if we keep these principles in mind, they give us a stance or a framework, if you like, for how we go about having conversations with people that are having these difficulties. And then this concept of dialectics, which I would love to talk a lot more about, but it's very complicated. So people with borderline personality disorder and other severe emotional problems live in a world of extremes and polarity. And I've kind of pointed that out. So, they have this idea that, I'm either good or I'm bad. I'm either loved or I'm hated. I'm either happy or I'm sad. And it can't be. Their experience is that it can't be both of those kind of things. And because, of course, because they have low self-esteem and history of all kinds of problems, they ultimately end up falling down on the negative pole of that kind of polarity of seeing themselves. So the dialectical worldview is about helping that person to start to move away from this kind of idea and start to understand and accept that maybe both those things can be true. In the dialectic worldview, every concept contains its opposite. So when someone is happy, there is sadness. When someone is fearful, there is courage and braveness. When someone feels shame, there is pride. and that there is no absolute truth from a DBT point of view. And this is kind of really important as well, because what you find, again, when it talks about the rigidity of people with these kind of problems, is that they often get caught up in this idea about what's right or wrong, or what's true or false about me. And therefore, what's the right way? So if I'm a failure, I'm a loser, and I'm worthless, it's true that there's no point in me having relationships with people, or even trying to have relationships with people. So the DBT view says there is no absolute truth. Truth is simply what works for you in order to make your life effective. So again, it's kind of moving people out of these kind of extreme views about themselves. There's always something missing in what we know and what we understand. So this is a concept that we can always deepen our understanding of ourselves and the world. And new truths are formed through the synthesis of old ideas. So I'll just leave that one. So the second idea that I want to talk about is the biosocial theory, which is really important for understanding people with these kind of problems. So according to the DBT approach, there are two things that contribute to development of severe emotional problems and the use of suicide and self-harm as coping strategy. First of those is that some people seem to be born with a propensity to just feel things more. And in our groups, when we talk to people in our groups and we ask them, do you think you're someone that feels things more than anybody else? Everybody puts their hand up and says, absolutely yes. So it turns out that people with these kind of problems, they have much stronger experience of shame and guilt and sadness and fear, but they also have much stronger experiences of love and connection and joy and fun. So they have much bigger, much richer emotional worlds. And it turns out that research has shown that interpersonal or emotional sensitivity is actually normally distributed in the population. So that means that for every highly insensitive person there is in the world, there's a highly sensitive person. And of course, the Americans have caught on to this. And in America, there is now a whole highly sensitive person movement. There are books on the highly sensitive person at work, the highly sensitive person at school, and so on. So this seems to be a genetic issue, but it can also be formed through exposure to early childhood trauma. So what can happen when someone in their developmental years is exposed to trauma is their sympathetic nervous system gets sensitized, and they can react in similar kind of ways to someone who has this genetic predisposition. And what's really interesting about these people is that they have a very different emotional profile. So whereas the average person, their emotions come on reasonably slowly, they kind of hit a middle ground level and then go off kind of quite quickly. Turns out that these people, their emotions come on very fast. They hit a very high level and then they go off very slowly. So they almost have an opposite emotional profile. The good news is, though, for any of you that are sitting out there feeling that you're a highly sensitive person, that is not the only factor that that's necessary for people to develop this tendency to use self-harm and suicidal and experience suicidal ideation. So some people grow up in what's called an invalidating environment. And this is really important because some of the models around will suggest that people who have these kind of problems have all experienced severe physical, emotional, or sexual trauma. But you meet a significant cohort of people, perhaps even up to 40%, who will experience their upbringing as traumatic, but actually can't directly kind of identify any of these more objectively traumatic experiences. And so this concept of invalidating environment captures that much more kind of effectively. So obviously, the concept of an invalidating environment, and invalidation is the experience that you as a person, your inner world, your thoughts, your feelings, your sense of being, your sense of self is somehow trivialized and treated as unimportant or even punished. Obviously, severe or any form of sexual abuse, severe emotional abuse, physical abuse are profound forms of invalidation. But for many people, it's just that they grow up in a world in which they just feel like they don't fit. So they may go to school, they don't fit in school. They may even feel like they don't fit in their family environment. They don't feel like they belong anywhere. And so what happens is you have these people that have these very big, kind of rich emotional worlds growing up in an environment in which they just don't have have any external anchors, if you like, any sense of belonging, any sense of connection, any sense of where they fit. And so there's no environmental regulation of kind of their emotional world. And so they grow up with these very erratic emotional worlds and this sort of sense of not fitting in and feeling invalidated by the world. Ultimately, if you grow up like that, in the end, that leads to self-invalidation, which is this tendency to tell yourself that there's things wrong with you, that you're bad, that you're flawed, that you're broken, you're not the same as anybody else. So according to the DBT theory, when you have someone who has this highly kind of emotional temperament, who grows up in an invalidating environment, they're the conditions in which that person has a high risk of developing these kind of problematic behaviours. So that's the biosocial theory of DBT. And it's very, very helpful theory for talking to people about these kind of problems. It's a very validating theory because you'll find that anyone you talk to about these kind of difficulties, they will almost certainly identify with this. I'll just quickly talk about the kind of sense of self as well. So a lot of psychodynamic theories hold that that things like borderline personality disorder are a consequence of an underdeveloped sense of self. And the theories hold that treatment therefore needs to be directed towards the person developing a stronger sense of self in order for them to regulate their emotions effectively. DBT flips that completely on its head. So DBT says that these kind of emotional problems are actually a consequence of emotional dysregulation. That is the inability to regulate one's emotions. And by learning how to regulate one's emotions effectively, a person develops a more consolidated and coherent sense of self. So it sees it as not causal, but possibly a consequence of these kind of difficulties. So a very different theoretical approach. More recently, DBT has been expanded. So original DBT was focused very much on a very broad kind of spectrum of disorders. In the last 10 years, there's been a new version of DBT that's been developed called RO-DBT. And now what we have is we have traditional DBT, which is aimed at disorders of under control, and RO-DBT, which is aimed at disorders of over control. So probably most classically obsessive compulsive personality disorder. Last two slides on DBT, and then I'm going to get into a bit of practical stuff. So this is a bit blurry, but it's quite a nice kind of tool, again, to talk to patients, to talk to patients about what it is they might be doing when they're trying to kind of deal with their problems. So what we talk about is we talk about the goal of the initial phases of dealing with self-harm and suicidality is to get out of the burning basement. So what we're working on here is helping you to get greater control over these behaviours that are potentially life-threatening. So suicide and self-harm. But also to help you get more control over behaviours that get in the way of you benefiting from the treatment and the work that we're going to do, and working on what's called major quality of life threats. So this is the kind of really most of what is considered to be DBT. And then what often then has to happen after that is that the person then moves into what's called stage 2, which is the treatment of their trauma and of their stress. So DBT is about giving people the skills to control their emotions better and to manage their emotions better and their relationships better. And then they would go and work on trauma. And again, this is quite different from a lot of other models in which trauma is the main focus of treatment. And we work on a risk matrix, a stratification matrix, where when we're working with our clients, the thing that we focus on most is suicidal behaviours, if they're present, then self-harming behaviours, then things that get in the way of us falling in an effective relationship with our clients, and then often the stuff they're coming in for. So often they'll be coming in for a relationship problem, but actually the issue is not the relation. The issue we need to be focusing on is the high-risk behaviours, the suicidal behaviours or the self-harming behaviours. So in DBT, part of it is about, and this is another tool that you can use when thinking about clients, this client group, is that often they will come in and start talking about a relationship problem. And what emerges actually is that what's happening is they're having a lot of suicidal thoughts, or they're having a lot of self-harming behaviours. So that therefore needs to be the focus of treatment. Okay, so that's a very quick introduction to DBT and the sort of concepts of DBT and the framework. And within that, there's a couple of kind of theoretical ideas that you can use. Now I'm going to move on to some more practical ideas about things that you can use in primary care as well. So the first of those I want to talk about is the function of self-harm. One of the difficulties people have is really understanding why it is that people self-harm. Quite often what happens is that all too often people see self-harm as being an attention-seeking thing, about the person's trying to get help or trying to get people to pay attention to them. It's really tragic to think that if that is the case and that's what's going on, what's that person's life been like, that they've learned that the only way that they can get people to actually pay attention to their needs is by engaging in these kind of really drastic high-risk behaviours. But actually, that's not what the research says. That's not what the research says about the function of self-harm. So what the research says is that people self-harm for two primary reasons. So in the presence of an overwhelming stressor, one of the things that happens is that person experiences intense emotion. They're feeling overwhelmed, they're intensely distressed. What happens is they self-harm, and that actually reduces their distress. So self-harm is thought of as actually being a coping strategy for intense, overwhelming emotion. And the research clearly indicates that when people self-harm, so when someone cuts themselves, they get a massive reduction in their distress. The problem with that is, of course, is what we know about the concepts of reinforcement, is that then reinforces that behaviour. And the person learns that by harming themselves, they actually reduce their distress. So it actually becomes an emotion regulation strategy. The second function of self-harm, so that's the primary function of self-harm, is to regulate your own emotions. The second function of self-harm relates to dissociation. So a smaller cohort of people, rather than experiencing overwhelming emotion, actually become dissociated and disconnected when they experience an overwhelming stressor. So they feel numb, disconnected, alone, and unreal. And of course, this is the kind of stuff also we see in things like depression as well, which is why Marshall Arnon was interested in possibly pairing this treatment for depression and why it's got such good outcomes for depression. So when someone's feeling like that, they self-harm. And what that happens is that makes them feel alive, real, and connected again. So these are the two mechanisms underlying self-harm. It's either a coping strategy to relieve intense affect, or it's a coping strategy to relieve dissociation. And it's rare that it's actually an attention mechanism, but pejoratively, that's often what people think is going on. And it's a real pitfall for clinicians working with people with self-harm, because if your perspective on it is that the person's doing this as a cry for help and to get attention, you'll be communicating that in some kind of way. The person will be picking that up and they will feel invalidated because that's not actually what's going on for them. So it's really important that you communicate to the person that you understand that they were probably either experiencing intense emotions and they self-harm to relieve that, or perhaps they were experiencing dissociation and they self-harmed in order to feel alive and connected, and to talk to them about what it actually is and how it works for them. That turns out to be a very, very powerful form of validation, because what it shows is that you actually directly and clearly understand what's happening for that person and that you accept what's happening for them and their experiences. So this concept of understanding the function of self-harm is a really important concept for you as GPs and should be driving how you interact with your patients who are presenting with these kind of problems. Now, it also turns out, by the way, I think I've actually missed this in my slides, that suicidal ideation works almost exactly the same way. So what happens is a person is experiencing, say, overwhelming distress, and then they have the thought, well, maybe I should kill myself. What that thought does is it does several things. First of all, it gives them oddly a perception of control. So it gives them the sense that actually they can do something about this overwhelming, uncontrollable situation, which is that they can end it. And the second thing that happens as a result of that is that they get a sense of agency and a sense of, oddly enough, this kind of odd sense that they can actually make a difference in their life. So what happens is that their distress gets relieved and their distress goes down. So the thought, I could always kill myself, actually is actually a positive reinforcer and reduces the person's distress. And that thought then can get caught up in a cycle where that thought continually comes up and it continually reduces the person's distress, and therefore it becomes more and more reinforced as a habitual kind of behavior and thinking process. Now that's more a kind of idea around chronic suicidal ideation. It's not so much a comment on acute suicidal ideation, particularly in people who don't have chronic suicidal ideation as well. But if someone's chronically talking about suicide, it's most likely because that thinking process has become reinforced by the fact that it relieves that person's distress. So it's really important to understand this kind of concept of, I did put it in there, sorry, this concept of reinforcement. And it's a really important aspect of working with people with self-harm. So this concept of reinforcement is the idea that reinforcement is a process by which the likelihood of given response is strengthened through the consequences of that response, right? So you go out to the shop to buy some bread, you find the shop is open, you buy your bread, you're much more likely to go back to that shop at that time and buy if you need bread because your behavior has been kind of reinforced. So according to the DBT model, self-harm and suicidal ideation are absolutely maintained through the process of reinforcement. So what's really important with working with people is to try and work out what it is that's actually reinforcing their behavior. Is it that it's relieving the affect? Is it that it's getting them out of dissociation? Or is it that it's giving them a sense that somehow they can control their situation and they can kind of get out of their situation? And again, when you understand that and you can start communicating that to someone, it's a very validating way of engaging that person in a conversation about what's happening. And what that means, of course, is if we think about this kind of concept of reinforcement, what we start to recognize is that effective help means reshaping these reinforcement contingencies. It's helping the person recognize that there are other things that they can do to cope with these kind of difficulties, and working on reinforcing that and building those patterns of behavior as new kind of patterns of behavior. So the concept of reinforcement, positive reinforcement and negative reinforcement, are really crucial aspects to thinking about suicide and self-harm. The next idea I want to talk about is validation. So, and this really is a central concept in DBT. And it's really interesting. As GPs, you may have a different view on this, but it's my understanding that there are very few medications that have been shown to be effective for the treatment of suicidality and prevention of suicide. I understand that things like clozapine and schizophrenia and lithium are exceptions to that, but certainly my understanding is that antidepressants in particular there's not great deals of evidence to show that they protect against self-harm. Now, that may be that, and suicidality, that maybe people here have a different view on that literature, and I totally accept that. However, through the micro research that Marsha Lynham has done on DBT, she has shown that validation is an incredibly powerful anti-suicide strategy. And in my work of working with people with these kind of problems, I've seen that time and time again, that using validation has been very effective in reducing the risk of suicide. And one of the most startling examples I've had of that, and this is about combining some of the assumptions of DBT that I talked about with validation and a thing called radical acceptance, which we'll kind of have a look at in a minute, was a lady that I was working with who came in to see me just before Christmas, and she said to me that she didn't think that she would be able to get through the Christmas holiday, and that she thought it was highly likely that she would end her life. And so I said to her, you know, over the last year or so, you've told me a lot about your life and a lot about the difficulties that you've had in your life. And while, of course, in my deepest part of my heart and the deepest part of my bones, I don't want you to hurt yourself. I just want you to know that your life really does seem is unlivable to you. But I know that that's the case, and that if you did, I would understand. it would make sense. And it was a really interesting thing to say to this person, because often when I say that, give that example, you're probably looking at me going, are you mad? Like, are you actually suggesting that this person should go and hurt themselves? But I wasn't. What I was actually doing was I was providing what I thought was a profound validation of that person's distress. And she came back after Christmas in the new year, and she said, you know what, that was the first time anybody really truly understood what it was like for me and how difficult it was for me and why I might want to end my life. And that was the thing that kept me alive over Christmas. And it was really a powerful example for me of validation and kind of what that means and how that actually works in actually protecting people from suicide and self-harm. So validation is the recognition and acceptance of another person's internal experiences as being valid. So this isn't condoning or agreeing. When someone comes in and says to me, I cut myself yesterday because my partner left me, I might say to them, well, I guess given that cutting yourself has been effective for you so often in the past, it would make sense that you would do that on this time or this time around. Now, what I'm doing is I'm validating that person's experience. I'm not saying it's a great idea to cut yourself, or I agree with you doing that, or I condone that. What I'm doing is I'm making a statement of my acceptance and understanding of that person's worldview. So emotional validation is distinguished from emotional invalidation, in which in which a person's own or another's person's emotional experiences are rejected, ignored, or judged. And self-validation is the recognition and acceptance of your own emotional experiences. So I mentioned before that these people have grown up in a highly invalidating environment and they've become self-invalidating. And so you as a clinician have the opportunity to provide an invalidating environment. And I can tell you that if the person that you're working with experiences the interactions with you as validating, there's a pretty good chance they're going to have a strong relationship with you. And there's a pretty good chance that that's going to help protect them against a whole bunch of kind of problematic behaviors that you're trying to help them with. So validation is incredibly powerful. And what does that mean? Well, on a most basic level, validation actually just involves showing interest and listening to someone. So if you're interested in learning about validation, it's worth Googling a thing called DBT levels of validation. And in that, you'll see these 6 things, which are considered to be 6 examples of increasingly more powerful validation. So the first of those I mentioned is showing interest and listening to someone, because once you do that, you convey to the person that they're actually important and that the way they see things and the way they live their life is important. The second is called accurate reflection and possibly checking for your accuracy. That's reflective listening. It's probably the kind of stuff that you guys have learned if you've done any kind of studying on counselling skills. It's just basically just reflecting back to the person what you hear. Reading thoughts and checking for accuracy. I'm wondering whether at the moment you're feeling a lot of shame. Is that the case? Behaviour makes sense given the person's history. So the example I gave before, well, I guess given that you've used self-harm so many times in the past to deal with this, it would make sense that you would do that on this occasion. So what's happening right now makes sense given your history. Behaviour makes sense given the current situation. Well, what you've told me is you were incredibly overwhelmed today when you went out and self-harm. So I guess it makes sense that would be what you would do. And then radical genuineness. This is a really kind of lovely idea, and it's kind of based around the idea that you treat the person as a capable human being and as an equal to you. So so the idea that the relationship between the GP and the patient is a relation of equals, that you are struggling in the same way that they are struggling, that you are in this together. And radical genuineness is about being honest and open with the person in how you're working with them. So so telling someone that everything will be okay and giving them a pat on the back when you don't believe that and they don't believe that is not being radically genuine. So radical genuineness is a really powerful strategy when it's used in an effective way. One of the ideas I really like about DBT and this sort of concept of radical genuineness is the idea of what they refer to as not fragilizing people, which is that we try to take the view that everybody has the capacity within them to be able to have honest, equal, meaningful relationships and conversations with their treating clinicians. And that person has the ability and the capacity to change things in their life in order to make things better. So it's a fundamental faith, really, in the person, and not treating them like they are, a broken object that needs to be kind of handled with kid gloves. Now that doesn't mean being tough or harsh or difficult. It does mean being empathetic and showing compassion. But it's about what we convey about how we see people and how we see their capacity to improve things and to change and grow. So that's validation. And I would encourage you to try using validation with any of your complicated clients and see how that works. Distress tolerance. So this moves into slightly different things. So in DBT, I talked about that there's a bunch of skills. And one of the kind of key areas of skills that's really useful and something that may be useful for you when you're working with people is about helping people to manage their distress in the current moment. So there's two things that we're trying to do. So if you're sitting in a room with someone, one thing might be about helping them to get through a crisis that's occurring in their life without making it worse. So that might mean getting through the fact that their partner's just walked out without harming themselves. Or it might mean getting through the fact their partner's just walked out without going around to their partners and tearing strips off them and making the situation worse. And the second thing about distress tolerance is helping the person to get through a day in a life that's not what they want. Because most of the time, if someone's very distressed and they're sitting in front of you and they're telling you about that, it's pretty kind of clear that they don't want to be there at that particular moment in time, but they kind of are. So distress tolerance is a bunch of skills that are about doing that. What we know is that when people self-harm, it really occurs in the context of a single event. Usually, it's quite common, by the way, when people self-harm, it's quite common for them to do that towards the end of the day or in the evenings. And that's because what happens is that there's often a build-up kind of events for someone. So as an example, a person wakes up feeling anxious, they're late for work, they get to work, they have an argument with a colleague, then they receive a hurtful text from a friend, and that leads them to kind of hurting themselves. So what distress tolerance is about, it's about helping that person have some skills to deal with these kind of difficult things that go on through the day. Because what we know happens is that when someone experiences distress, as that distress grows and grows and grows, it reaches a certain point where that person feels like, and I'm sure you guys have all had that experience before, I know I have, where you feel like when you're feeling anxious or overwhelmed or shameful, that it feels like this is just going to go on forever. And that's all there is that kind of experience. So for what happens for people is that they try to, if you like, jump off that distress curve. So they may jump off that distress curve through drugs, through overeating, through harming themselves, through alcohol, from just running out of the situation or getting angry. There's a whole bunch of things that they do to jump off that distress curve and get rid of those difficult emotions. What we know, however, is that once you've done that and you've found that to be effective, you're more likely to do that again. So it's become reinforced. But also, why would you wait for the distress to reach a high level of intensity? If you know that's what's going to happen, you're going to be overwhelmed, and you know these other things work, what you would do is you would just do that earlier and sooner. So what we see over time is we see people using these coping strategies with much less and less intense stresses and much more kind of regularly and much more frequently in their life. But it's all about jumping off this distress curve. So what we do with distress tolerance is we're trying to get that person to stay with that curve. So we're going to say to the person, look, we're going to talk about a whole bunch of things that you can do and a whole bunch of skills that you can use in order to try to ride out this distress curve. Because what we know is that if you can get to the other side of that, then that is a new experience for you. And you will then learn, that will get positively reinforced, and then you will be more likely to use those more adaptive skills in the future. So you can talk to your patients about this and about using a whole bunch of skills to just get through this so that you can see the other side of the emotion, so that you can experience this emotion coming down. And I put this on, I think you'll probably get these. This is a great website, Sunrise, which has like a full range of DBT, distress tolerance skills. There's probably 100 different skills that someone can use, and you can use with a person who's in this situation. What's really important though, and we talked about invalidation before, is that we don't go down the path of conveying to the person that actually this is actually really simple, and that all you need to do is just flush some cold water on your face, and everything will be fine. Because that's a profoundly invalidating thing to say to someone, to say this will be fine, you just use some skills and everything will be okay. So what we're saying to the person in a validating way is we're saying, look, we've got to get you through this moment. We've got to help you do anything you can or whatever you can to stop yourself from hurting yourself, from drinking, from overeating, from escaping the situation, so that you can experience this differently, so that you can learn skills in order to deal with this thing in a different way. And so I'm going to give you some ideas, some skills, some things that you can do to get you through this. And it's all hands on deck here. The goal is to get you through this as much as we can. So you're being very validating in doing this. You're not saying it's just a simple thing about skills. You're recognizing how incredibly difficult this is for the person. But you're also trying to communicate some things that they can kind of do to deal with this. So I'm just going to show you this kind of short video on, I'm hoping this will work before.
Doing a service for someone else, such as helping your mom cook dinner. Service is not only an activity that will distract your mind, but you'll also brighten your day by helping.
Oh, hang on, sorry.
When you're feeling tormented by a situation you can't do anything about just yet, use the distress tolerance acronym ACCEPTS. This stands for activities, contributing, comparisons, emotions, push away, thoughts, and sensation. These techniques are designed to keep your emotions manageable until you can resolve the problem. Engage in any healthy activity you can think of. You can watch a movie, take a walk, or clean the house. Being absorbed in an activity will keep your mind off the situation until you're able to address it. Contribute by doing a service for someone else, such as helping your mom cook dinner. Service is not only an activity that will distract your mind, but you'll also brighten your day by helping someone else. Compare your present situation with the time you are coping with a more difficult life issue or with the circumstances of someone suffering in a third world country. This can help you put your life in perspective. Invoke the opposite emotion of your current distressed feeling. For example, if you are feeling depressed, you can watch a funny video. If you can't deal with something just yet, it's okay to push away the problem out of your mind temporarily. You can even set a time to come back to the issue so you know it will be addressed and can relax in the interim. Replace negative, anxious thoughts with activities that distract your brain, such as counting to 10 or doing a puzzle. Practice self-soothing behaviors, such as taking a bath or eating your favorite food, that will appeal to your senses and help you relax. These actions help you tolerate distress until the appropriate time to resolve the situation.
So I just want to point out, as I say, this is the important thing about the DBT frame, right? Is if you just showed someone that video and said, here are some things that you can do to deal with this overwhelming situation, you would most likely deeply offend most people who would probably feel, how can you suggest that this is the solution to this terrible situation I'm in? And it would be a profoundly invalidating thing to do. However, if you use the other things we're talking about here, so thinking about the DBT assumptions and the framework that we're using, thinking about these concepts of distress tolerance that we're talking about, thinking about the concepts of validation, thinking about the idea that what DBT is a way of structuring and approaching therapy or treatment for a problem, right, in order to help the person learn these skills. So what you're trying to do is you're trying to frame what you're doing here in order to get the person to go and use these skills, because what we're trying to do in this particular case with distress tolerance is get the person to do whatever it is they need to do in order to get through this distress curve, for them to see the other side and to see that actually they can get to the other side without harming themselves. So when you do it like that and you frame it like that, it then becomes a much more validating thing to do. And I would definitely discourage you to not just kind of poke a bunch of these things under someone's nose and say, why don't you go and do this and everything will be fine? Because you will most likely be quite unsuccessful if you do that. So this is this concept of the way you structure things, the DBT frame, and how we communicate these things to people is kind of what's crucial. Someone just put in the chat there was a problem with the link, and so I'll update the slide to make sure that that's accurate. So stress tolerance skills are a really important skill for you to use with your patients, but they're all about, as I say, all about getting through this kind of overwhelming thing that's happening now, tolerating a day that you don't want to be in. That's kind of what they're about. And when you frame it like that to the person, it starts off as a very kind of validating type experience for them, and they're much more likely to then use the skills that we're sort of talking through to try and get through that situation. So distress tolerance is really important. The next thing I want to show you is radical acceptance, and then we're going to move on to our case. I just want you to watch this video because I think it's a really important video. So this is Marshall Arnhem. It's the person who developed DBT. Sorry, it's unfortunate the borderline of notes has been unfortunate.
I've been transformed by the very therapy that I developed. Because once I realized that I had to teach the clients acceptance, I realized at that very same moment in my own personal life, I had somehow lost my ability to accept, and that I was going to have to learn it myself. And so I ended up taking a sabbatical point or time off from my job. What I found out when I went to the first Buddhist monastery was within days, I knew that I had found exactly what my clients would do. I had no doubts about it. I figured that out right away. That acceptance was exactly what they needed, but that they had a way of teaching it that I could translate. And my problem was I tried to take it stock and barrel to my client. At Shasta Abbey, the basic message was all the time to try to radically accept everything and to let go of desires and what you want. So we got jobs every single morning. And so it was the idea of practicing letting go of wanting a particular job. If you were sweeping, they would tell you when the bell rang for work to stop, they would tell you stop in the middle because finishing is just your own thing. You're trying to do something you want to do, just let go. So it was this whole practice of just constantly, moment by moment, letting go of what you want and radically accepting what is. It was the first environment I'd ever been in. It was completely non-sexist. I thought I'd died and gone to heaven. I'm not kidding. It was so unbelievable. Men and women would get the same jobs. There was no real distinction. I mean, admittedly, it may not have been helpful if I had just completely thrown myself into it. But since I decided ahead of time that I had to learn this, my only option was just to do everything I was told, just throw myself in. And I was a student, so there were 8 of us. We did everything together. It was really the practice of letting go of having to have what you wanted at any moment. And the recognition that you didn't have to always have whatever it was you want. That had a big effect in some ways on the therapy, that in the sense that I try to teach clients, suppressing what you want is not the way to go. You have to radically accept that you want something you don't have, and it's not a catastrophe. And so I stayed there for 2 months. Then I went to Germany to the Catholic priest. It was actually the first time in my life I ever talked to someone who actually understood me, the spiritual part of me. Given that my spiritual part of myself is the core of myself, more central than anything else about me, having that understood was an amazing experience. It had a transformative effect on me. What it did is it gave me a home. I am now convinced that It was the practice of radical acceptance every moment. That will transform you. I don't have the slightest doubt. It would transform everything. But it has to be a regular practice. And radical acceptance doesn't mean you don't try to change things, because you only have to radically accept the moment that you're in and the past. But you can try to change the next moment. You can't change anything if you don't accept it, because if you don't accept it, you'll try to change something else that you think is reality. So radical acceptance is simply the radical acceptance that reality is what it is. And if you want to change it, then you work on changing it, which is perfectly legitimate also. But I think it's hard to change something if you don't accept it in the first place.
Okay, so when I spoke earlier, I talked about one of the assumptions of DBT is that the principle is applied to clients and to us at the same time. And this is a really good example of this, is working with people who are self-harming and suicidal. It's really important for clinicians to practice this concept of radical acceptance, which is this idea that perhaps I don't want to be here at the moment. I don't want to be in this situation. I don't want to be having to deal with this highly suicidal or kind of high risk patient, but I am. And the concept of radical acceptance, according to the sort of DBT view, is the crucial role in validation and acknowledgement of what's happening and of your current experience. So it's really important to be able to say, I don't want this. This is not where I want to be, but I am, and it's not a disaster that I'm here. And it's that kind of piece about acknowledging that actually what you want is something and you don't have it. And in doing that, we can use that with ourselves, but we can also use this kind of concept with our patients as well. And this video, it's 4 minutes long. It's something that I would show to kind of most of my clients that I'm working with. If I'm talking about kind of acceptance of the current moment, about dealing with where you are at the moment, in order to de-escalate the emotions, in order to reduce the risk of self-harm or suicidal behavior. So this is radical acceptance. So I've really given you guys a kind of toe in the water into a bunch of DBT kind of concepts there. And I've given you 4 or 5 concepts. I've given you the DBT framework. I've given you the DBT kind of formulation kind of ideas around the biosocial model. And I've given you, hopefully, some practical ideas of how to think about how to sit with people who have these problems, how to frame the conversations that you're having with these problems. And in the case of some of these things, actual skills that you can either use for yourself when you're dealing with these people, or skills that you can actually communicate to your patients that they can use. But the important thing about that is how you frame that in a way that's kind of validating for the person. So now we're going to do a small group exercise. So I'm going to present a case. So Ashley is a 24-year-old art student who works part-time in a jeans store. Ashley hates their job, and in particular their boss, who they describe as selfish and manipulative. Ashley is single and lives with 2 friends in a shared house. One of their friends recently started a relationship, and soon afterwards Ashley fell out with a friend over not helping around the house. Ashley now wants the other friend to agree to ask the first friend to leave the house. Ashley binge drinks alcohol and uses recreational drugs at parties. They're known to go out for whole weekends and go home with people they've just met. Ashley willingly describes himself as promiscuous, doing so with a degree of shame and slight gloating. Ashley experiences brief periods of low mood and anxiety. At times, Ashley will cut superficially to cope. However, Ashley finds that being around people constantly is a good strategy to avoid self-harm. At other times, their low mood and anxiety can be prolonged. Ashley has presented to the local emergency department several times feeling suicidal, typically feeling that everyone hates them and they'll be better off dead. Ashley was born in country New South Wales. Their father ran the local pub. He drank excessively and was often violent to the children and their mother. Ashley's daughter assaulted Ashley's mother on multiple occasions, often with Ashley present. Ashley is confused about the anger they feel for their mum and the desire to be accepted and loved by their father. Ashley also gets angry in relationships and cannot understand why they act, quotation marks, like my dad. So this is a kind of a bit of an amalgam of a number of cases that I've seen over the years. Ashley comes to an appointment with you late in the afternoon. They tell you that it's been a terrible day. Their friend has told them that, in fact, they want Ashley to move out. Ashley feels that this is a disaster and that homelessness is inevitable. This means Ashley will have to stay in their job, which they hate. Ashley has a strong desire to get drugs and just wipe themselves out for the night. Ashley feels that unless they do that, they'll cut themselves to cope, not to come, to cope. Okay, so you've got 10 minutes to talk to Ashley. Think about the DBT framework and the key ideas we've discussed. How can you engage Ashley in the discussion and help them find other ways to cope? I mean, I guess I just point out as well that in this kind of brief workshop, what I'm trying to do at the moment is just give you some introduction to some ideas, you know, and there are lots of online resources that you can use to kind of train in these. What I might even do is I might put together a kind of list of some short videos and things like that you can do, and we can circulate that round to you, because it does take a lot of there is a lot of things that you can kind of explore with this stuff, and we don't need to get too caught up on this kind of this radical genuineness thing. But I think the idea of it in the validation, would be to say to the person, rather than, you're right, you're not making it about you, is you don't have to, because if you say, well, yeah, I can see why your day's worse than everybody else's, well, that's just kind of actually being kind of ingenuine, really, in that situation, So validation is about recognizing the person's experience without necessarily agreeing that it's correct, or saying it's correct or you agree with it, So it might be a case of saying, yeah, I can hear that this day feels like kind of the worst days, one of the worst days that you've had, and you might connect with that feeling in yourself in order to kind of convey that, Feeling that yourself about what it's like for you helps you to kind of communicate that kind of empathy to the person. But it's tricky. So you're right. So validation isn't about saying, oh, I get it because it happens to me. But validation is actually about that communication to the person, that you understand how things are for them in that situation.
Tony, just on the point of resources, we have a question in the comment section. So are there videos, vignettes of DBT in action we can watch, similar scenarios to the one we have done tonight?
Yeah. So I might put together a little list, and if I can give that to you, and we can circulate that round. If you just Google Marsha Lynham DBT videos, there's lots of little short, kind of 2 to 4 minute videos on all kinds of concepts and ideas in DBT. And so you should be able to find some stuff. You can do, if you're interested in doing any like short courses on DBT, then there's PsychWire. So that's PsychWire, W-I-R-E. They are now, where Marsha Lynham's training company, the Lynham Institute, now does all its training through PsychWire. So you can do things on there that are quite good and quite useful as well. Fairly inexpensive as well. They're all kind of online things, and they cost about $300. But like in doing this, putting this workshop together today, I really attempted to do something a bit different, is to introduce you guys to a bunch of evidence-based concepts that we know help to reduce the frequency and severity of suicidal ideation and self-harm, but it's quite different because it's all about these kind of interactions and these conversations and these frames and so on. So it does require a kind of radical rethink, and I do think it was ambitious to try and do it in 2 hours, but I wanted to kind of give it a go because I thought it might help you guys on a starting a bit of a path to take on these kind of ideas, Any other comments about the exercise before I open it up to sort of general questions? Okay, so any general questions about suicide, self-harm, anything about patients? Oh, that happened quickly. Lots of food for thought. Okay, thank you. Yes, yeah. So it does refer to lifeline help. Yes, absolutely. So if we go back to the distress tolerance skills thing, the concept of distress tolerance is to do whatever you can and whatever the person can to get through that experience. So Lifeline definitely will be something that would be very, very helpful. But I would be doing that in a DBT frame. I would be saying to the person, look, we're going to get you in touch with Lifeline. They're going to provide you with some support. And then we're going to talk about this next week. And when you talk about it next week to the person, I want you to, you've got to be saying to the person, look what happened there. You did something different and you got through it, So you're actually able to use Lifeline to tolerate that distress. It was really hard, but you didn't hurt yourself. Maybe you drank a bottle of wine instead of 3 bottles of wine. You didn't write yourself off. Maybe you didn't escape the situation. So again, it's about that kind of reinforcement and reflection about the fact that the person has actually done something different. And did your distress come down from Lifeline? What was that like? What would it be like for you to do something different again, as opposed to hurting yourself in that situation? So you're trying to build that, reinforce that behavior and build those skills around accessing other types of help and other types of support. Thanks. And what other services help can you suggest? Absolutely. Certainly, and I know this has changed quite recently, but one of the services that we connect with and is engaged is the Way Back. I don't know if you guys know about the Way Back. So the Way Back is an NGO I think is funded by the PHN, and they provide a crisis support service for people who've had a recent episode of suicide and self-harm. It was connected to emergency department presentations, but I don't think it is now. So anybody, I think, and you need to explore this because sometimes these services change their frameworks, but so if someone has had a recent episode of self-harm or suicide, they can get up to 3 months of case management from the team at the Way Back, and they will provide that person with support over the next few months and help to try and connect them up with services. We also know that some of the public hospitals have services, so like St Vincent's and George, the Gold Card, the Green Card, those kind of services. So again, they're services that are attached to emergency departments. And again, what happens then is that someone who goes into the emergency department can have 2, 3, 6 sessions of kind of no questions asked, kind of help around their self-harm. And that's been shown to be really successful. I know St Vincent's do it. I believe Prince of Wales do it. I know that St George did it. I'm not sure if RPA does it or Concord. But again, I'd be thinking about looking up who provides those services. And if you are referring someone to an ED, to try and push them towards a hospital where those ED are providing those services.
Tony, I might mention that there are also safe havens now, an alternative to ED for suicide.
Yeah, please. Can you mention that as well?
Yeah, so LHDs have funded programs so that people, instead of entering ED, they go to a more peer service, which is about more of a peer-led model. So they're called safe havens. So the LHDs, so there's one in Camperdown that I know of, one in St George. There's a children's, there's a CAMS safe haven in Randwick. So yeah, safe haven is just an alternative to ED. So rather than person going to ED, they go towards they go to a safe haven, which is more of a peer-led rather than a peer-led model for people experiencing extreme suicidal ideation or extreme distress.
Because the emergency department is an incredibly immersive experience for people. Even though emergency departments are trying and they get better, it's not a great place to be. You really don't want to be there unless you have to. Someone, Louise, made a comment about the helpfulness of DBT with chronic suicidality. Good to know. So I just want to make that point really, that from a DBT point of view, we always start from the premise that the reason someone does something is because it works. you know, and it's around that kind of concept of reinforcement. So whatever someone's doing, they talk about, you know, looking for the kernel of wisdom in the person's behavior. Why is it that you drink so much? How does that work for you? Why is it that you keep ending these relationships? Why is it that you punch people and get out when you get upset about stuff? And it comes from the assumption that the person is actually an effective human being in the context they're in, and the behaviors that they're using is effective in the world they live in and the context they work in, they exist in. That makes sense. And it's a really important and powerful kind of assumption that we make about working with people with these kind of problems. And again, it's very kind of validating to make that assumption that the reason the person does this is because it works for them in some kind of way. You know, anger is a great example, actually, you know, is that, you know, when people get really angry, they control their world, and they often stop bad things from happening. Of course, we know that often their behavior contributes to a whole bunch of other bad things happening, but why do they keep doing that? Like, why do they keep being angry? And the chances are because something's reinforcing it. You know, something's happening for them that's working. Even though we may see it as quite dysfunctional, there's a truth in that for that person. There used to be a flying squad mental health team that would contact people with mental health crisis and if necessary see them. This was disbanded. Is there anything else similar we can use? Do you mean, like, if you mean the mental health crisis teams, then yeah, I mean they're certainly still around, but I think most of us would have had the experience that the mental health crisis teams are very overwhelmed, and they often provide such short-term support for people that it often comes back to you guys, really, you know. So I think these other services like the safe havens and the way back and those kind of services are much more useful if you can access them, you know. Okay. Well, we're at 9 o'clock. So I think we've come to the end. Thanks everybody for coming along and being here till 9 o'clock on a is it Thursday night? On a Thursday night. As I say, I tried to do something a bit different, take a bit of a risk, and try and provide you guys with a bit of a different approach to working with this group of people. There's a lot more learning you can engage in if you're interested, and I can assure you that it does work, but it's not easy. It's not easy, and I'm not going to give you any kind of whitewash to think that it is. But this stuff does work. The evidence says significantly shows that this stuff makes a big difference.
Yeah, so thank you, Tony. Thank you for the presentation, and we hope that you all got a lot out of it. For everybody else, thank you again.